The recording will be posted on the board's webpage shortly after the meeting. TBW is also streaming this meeting live and archiving it for additional viewing opportunities. For everyone's reference, today's agenda can be found under the first tab in the meeting materials. And Sue Birch, Chair of the Healthcare Cost Transparency Board, will now call the meeting to order.
Thank you, Mandy. It's like that gavel, water bottle. Left it upstairs. Welcome, board members. I am getting a text on a phone from some board members. Can I just ask those of you calling in, Eileen Cody, gonna come off? There she is. Mute and tell us you can hear us. Yes.
Yep, it's fine.
Great. Okay. So it is 2:05. I'm calling the April 10th meeting of the Healthcare Cost Transparency Board to order. I want to give a warm welcome to everyone joining us today for our April board meeting. We are expecting a few more board members coming in person and online. So we will announce, or staff, you can update me as we see others come in. As we know, rising healthcare costs are one of the biggest reasons people delay or forego healthcare, which leads to higher hospital utilization and continues to perpetuate the problem of rising healthcare cost growth. Today's meeting provides a really unique opportunity for us to talk with Noam Levy. Noam is KFF's senior journalist who has been investigating and chronicling the issue of medical debt in the United States. Noam is going to provide background on the scope of the problem of medical debt in America, the drivers, and the possible solutions. In the board packet under tab 9 is a one-pager on the impact of high healthcare costs in the state of Washington, created for the board and the board's use. Under tab 10, there are also some additional articles on medical debt in America. And before we dive into that, I am going to take roll call in just a minute. I will also point out that New York Times had a very interesting article just yesterday. I know many of you have either sent it to me or texted me and said, are we going to talk about this? So we'll have time as Noam presents. So let's do the roll call. First, Jane Beyer. Here. Eileen Cody.
Here.
Thank you. Lois Cook. Here. Great. Bianca Frogner.
Here.
I think that was a here.
Yeah,
Yes.
here. Sorry.
Great. Jody Joyce. I think Jody might still be on medical leave. Jody? No. Greg Marchand?
Hi, Sue. I'm here. Can you hear me?
Yes. Hi, Greg. And I just want you to know I flew safely yesterday, Greg. Thank you. Okay. Mark Siegel. Mark, are you on? Mark might be joining us shortly. Margaret Stanley.
Here.
Thank you. Welcome, Margaret. Ingrid Ulrich. Here. Great. Kim Wallace.
Here.
Hi, Kim. Carol Williams. Here. Thank you. And Edwin Wong.
Hi, Sue. I'm here.
Great. All right. Let's do a quick overview of the agenda. Our next item will be the approval of the February retreat meeting summary. After that item, we'll hear public comments. Then we'll move into a legislative update and information about the leg session with a focus on the legislation with impacts on healthcare affordability and cost containment. After that, we'll hear about the new charges for the board under the newly passed legislative House Bill 1508. Then we're going to have Noam present, and we'll discuss medical debt in America and here in Washington. After that, we'll strategize next steps for the board and its work plan for 2024. And then we'll wrap up and conclude the meeting. So this is fabulous. Full day, and we'll just keep moving right along. So if you will look at tab 2, that is being summary that's being shared on the screen. And if I could get, let's see. Oh, I do want to just remind everybody that the recording of the last meeting is posted on our webpage for reference or review. And we will use the consensus process for a vote on the approval of the meeting summary for February. Is there any discussion on the February meeting summary or any proposed changes that anybody would like to see?
In the section under Office of the Insurance Commissioner's preliminary report,
the second to the last line, it says and more that, it should be and more than.
Thank you for that correction. Any other edits or changes? All right, if not, is there a motion to approve the minutes? Thank you, Jane, and great, thank you, Carol. All in favor, say aye.
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 Great, any opposed? All right, looks like we have unanimous approval. For this meeting, we're gonna move into public comments early, because we have made that a priority. So I am asking Mandy to tee up the list of folks that have raised their hands that want to provide public comments. And in addition, I'll just remind everybody that written public comments received since our last meeting can be found under the 10th tab in the board materials. And we allow individuals to sign up to provide public comments before the meeting, and we'll start those that have signed up and got into the queue first. If you have not signed up and would like to provide public comments, please raise your hand, and Mandy will call on you. And I remind you that when you're called on, please state your name, your affiliation, if any, before speaking. And also, I remind you that you have to accept the invitation to become a panelist in order to provide public comments. You're also, again, reminded that you can at any time provide us written comments via email anytime during the month, and we receive those. And Mandy, why don't you go ahead and start off with the names of individuals and who signed up?
I will check Shepherd and you.
Yeah.
Welcome.
Go ahead.
Half the Washington State Medical Association and our 13,000 physician assistant members. My name is Jeb Shepard, Director of Policy, and I'm thankful for the opportunity to provide comment during your meeting today. And it's really great to be here with you all in person. We hope that you've had the opportunity to review the letter that we submitted in advance of this meeting. That letter is sort of broken out into two parts, so I'd just like to provide for my comment today an overview of that letter. The first piece in the letter is some rare good news on this issue. We shared a new Forbes advisor study that ranks states in terms of patient affordability over 9 metrics. And I'm pleased to report that Washington State ranks 3rd, only behind Hawaii and Michigan. We'd urge you to review the letter for a link to that survey. And then we list the affordability metrics that Washington is doing well on. Increasing healthcare costs and affordability challenges, much like inflation, is a national trend, but we're doing some things right in Washington State. And I think personally, we can credit our shared success in part to the collaborative nature of our legislature, policymakers, and our healthcare system. We've worked together really well over the years. Mostly, there's the BRE Collaborative, CMO Safe Tables, the Washington Health Alliance, and many groups in Washington State play an important role in keeping healthcare costs down. These successes represent a lot of dedication and hard work that have helped move the needle despite national trends that are largely outside of our control. So our request that as you continue your work in 2024, we ask that you don't abandon wholesale the incremental collaborative progress for more blunt instruments. The second part of our letter is in response to the work items that you all selected at your retreat in February. We were asked on the advisory committee to provide feedback on those. In one of the first letters that the Medical Association wrote to the board in October of 2021, we noted the following. WISMA acknowledges that healthcare in this country is expensive and that cost containment is an important component of efforts to expand access to healthcare and insurance coverage. We also feel it is imperative that any recommendations the board makes to reduce cost not be disproportionately imposed on one component of the healthcare industry. Blunt and arbitrary tools will harm many medical groups, potentially putting at risk their overall financial viability. we're disappointed that the board selected topics at the retreat that are wholly or largely aimed at providers and not other areas where we could make progress. Simply addressing the macro cost drivers without addressing the underlying strains on practices will make practice viability more challenging and worsen access. We urge the board to approach the policies that were selected deliberately and as an alternative, suggest consideration of recommendations that lean to proven and successful, if incremental approaches that have landed our state near the top in terms of affordability relative to other states. These are things like a significant and intentional shift in care provided from the inpatient setting to the outpatient setting as demonstrated by OnPoint's study on cost growth drivers, investments in preventative and chronic care management, increased resources that ensure physician practices and medical groups can continue to treat all patients in their communities, preventing more costly downstream care, support a shift to value-based payment, and reduce administrative burden for both patients and physicians. On administrative burden, the board voted to defer to the Universal Healthcare Commission, who is also studying administrative burden. Would just urge the board to coordinate to make sure the charges of those two groups are different, to make sure that you're getting the information you need to make recommendations. And I want to thank Andy and the Healthcare Authority for proactively reaching out to WISMA to ask that we participate in the meeting in June to provide our perspective on the challenges our members are facing. Finally, in your report to the legislature, we urge the board to consider and include both the positive, like lowering costs, and the negative, like a loss of access, potential outcomes of each policy discussed so that lawmakers can make informed decisions. We look forward to continued collaboration and success. Please consider us a resource.
Great, thank you very much for those comments.
Next, I have Diane Lake.
Diane, welcome. If you'll identify yourself and your affiliation.
Thank you. I'm Diane Blake, CEO of Cascade Medical in Leavenworth.
Thank you, Diane. Go ahead.
Okay, thank you. So Cascade Medical is a public hospital district. We run an ambulance service, a rural health clinic, and a critical access hospital. And I would say for us, our critical access hospital and rural health clinic designations are really essential for us. It means that nearly all of our costs, not quite all, but most of our costs to treat Medicare and Medicaid patients are reimbursed at cost. It's unclear to me how the work of this board could impact cost-based reimbursement. But I'll say that paying less than cost of care would threaten already fragile financial position of rural hospitals. I have concerns about the policy levers this board has selected to take a deeper look at, but today my comments focus on the rate setting and price growth caps, mostly because of the challenge these pose, I think, to maintaining access in an environment where many costs are driven by external factors. For example, at Cascade Medical, 69% of our total operating expenses are for our people. That means wages and benefits. So nearly 70% of all of our costs are for people. This is a similar percentage that's experienced even in the rural and larger hospital setting. Healthcare is really a people business. At Cascade Medical, we track a statistic of the average cost of salaries and benefits per FTE per year. So in other words, this means on average, we're looking at how much does it cost to employ a Cascade Medical team member each year. Our per employee cost has risen over the past 4 years annually by the following amounts: 5.6%, 3.7%, 11.7%, and 9.6%. Since a large majority of our costs are for people, it's unclear to me how we could hold our cost growth to 2.9 or 3% per year. We don't set the market rate for wages. We try to meet them, frankly. So if I choose not to meet market wage demands, my workforce will leave to go where they'll be paid the going market rate. Washington ranks 5th highest in the nation for registered nurse pay. To not meet the going nurse rate, for example, means not having nurses to serve our community. We also don't set prices with our vendors for supplies, pharmaceuticals, and services. An example of this is that in 2022, the teleradiologist company that reads our x-rays, CT scans, mammograms, came to us and said that they were increasing their costs by their price to us by 20%. And they gave us a very short window to decide to continue doing business with them. Ultimately, there weren't any other options. And we took the 20% price hike because we needed to maintain those services for the community, even though we knew we would be losing money on those because our payments are already set. So those are just a couple examples about sort of the practicalities for us. And I would just thank you for allowing me to make these comments. And I urge you to consider the impact of external cost drivers on hospital operations and how access to care is really closely tied to those costs. Thank you.
Thank you for those comments, Diane.
Adam Zarin.
Adam, go ahead and open your camera and introduce yourself, please, and your affiliation.
Great. Thank you, Director Birch, members of the board. My name is Adam Zarin. I'm the Director of State Government Affairs for the Leukemia and Lymphoma Society, also known as LLS. Our mission is to cure blood cancer and improve the quality of life for patients and their families. Patients in Washington and all around the country feel trapped by medical debt. According to a recent LLS national survey, nearly 7 in 10 U.S. adults say they receive medical bills they cannot afford. And Washington has responded, making significant progress on creating strong charity care standards and improving access to high quality and affordable health care. But patients continue to see rising healthcare costs, sometimes nearly double inflation. And that means patients have to choose which bills they'll pay, rent or medical bills. So why is this still happening? In short, a few large health systems are increasingly purchasing local healthcare systems, hospitals, and doctors' offices. Those big health systems are gaining more control of their markets, leaving insurers and employers with less leverage to negotiate lower costs. These increased costs are passed on to consumers and patients through higher premiums, out-of-pocket costs, and even lower wages. These are well-researched and documented facts about our healthcare system. So what can policymakers do? LLS released a report entitled Healthcare Consolidation is Raising Prices and Jeopardizing Cancer Care, Policymaker Recommendations, outlining possible pathways forward. We appreciated this opportunity to share that information with you. We've included it along with some written testimony, and we hope to engage the board on a future time. Thank you so much.
Thank you, Adam, for that information. And I believe that attachment will be available online because I came in late, Adam, but we will make certain that the general public has access to that. Is anybody else?
I have Emily Bryce.
Emily Bryce, go ahead and open your camera, please.
Good afternoon, everyone. Hi, I'm Emily Bryce, Deputy Director of Northwest Health Law Advocates, a nonprofit that has worked to improve access to care for Washingtonians for 25 years. Thank you very much for the opportunity to comment today. First, I'd like to support the board's overall policy direction from the February retreat. The board heard from other states whose benchmark bodies has successfully offered a chance for healthcare stakeholders to come together to work on broad market problems that are affecting overall spending as well as consumer affordability. And in keeping with that approach, the board selected policy explorations to explore that will offer that chance for us to dig in together to issues that matter for Washingtonians. I did notice one stakeholder association submitted a written comment outlining concerns with the board's approach. And that comment, along with subsequent conversation at the Provider and Carrier Advisory Committee, and again today in some of the earlier comments, troubled me in a couple of ways that I want to outline. First, the letter suggests that there is no room for cost savings in the system without cutting jobs or needed health services, and I respectfully disagree. To give just one example, the Washington Health Alliance issued a report at the end of last year that indicates an opportunity to eliminate over $126 million in waste from the system, and further estimates that these dollars could provide 2,000 Washington families full insurance every year. I'm disappointed to see the attitude from some of our stakeholders that there is no room for change. Second, the letter suggests that the policy options selected are not relevant or supported by data. Again, I respectfully disagree. We do have data that suggests these issues are relevant to Washingtonians. To take the example of facilities fees, Department of Health data indicates that facilities fees were added to more than 1 million patient visits in 2022 in Washington, and that amounted to more than $118 million in extra charges. Third, the letter suggests that Washington costs are always low compared to other states. In fact, data from the Washington Health Alliance and Washington Care Compare suggests there's significant variation in prices charged to patients, which again indicates there may be room to find savings. With that said, I do agree with the letter that there's a need to dig into the underlying cost drivers, and I hope there's room to explore all these issues in a collaborative fashion in coming months. Second and last, I just want to reiterate to the board that your work matters to people. We heard a little bit about that from Adam earlier, and later we'll hear a presentation on national trends in medical debt. And I want to acknowledge, as Adam did, that Washington has done good work. We have lower medical debt trends than in some states, but we need to continue to finish the job because the consequences are so severe for patients if we do not. I work pretty regularly with legal services lawyers and talk with them about the challenges that their low-income patients face as a result of medical debt. And I'll give a couple examples before I conclude. People who enter collections and have a judgment for their medical debt have a 9% interest rate that can last for 20 years. And in some cases, that interest rate can rise to 50% of the principal in Washington. Creditors are able to garnish up to 20% of every paycheck and can wipe out all but $1,000 in a bank account with no notice. Medical debt over $500 remains on credit report for 7 years, making it harder to get a car, qualify for rental housing, or do other things that contribute to economic stability. And all this debt causes stress that can lead to worse health outcomes. So I appreciate the board's work to learn about the different ways that healthcare costs are impacting patients and people, even as you continue the important data and policy work ahead in parallel. Thank you so much for your consideration.
Thank you, Emily.
I do show that there's 2 other hands raised, but I do note that we are 7 minutes over schedule. I'm happy to encourage, and one of them is Katerina Romarsh. I know she submitted her comments via writing as well. I can encourage the remaining 2 to submit via writing, or we can continue. What would you like to do?
Would like to continue the public comments so that everybody has equal time. I would just remind commenters to please try to keep to 2 minutes, especially Katerina, you're up next, and we do have your written comments, but go ahead and open your camera and identify yourself. Or if you're yielding your time, just let us know. Is she opening up?
Oh, hi, thank you. I have a little bit of unstable internet, so I'm probably gonna keep my camera closed. But I can, if it's helpful, submit my comment in writing. I was just gonna speak to the medical debt piece. To save time, if I think Krista Abel, one of your advisory committee members, is the second person who'd like to provide comment, so I could defer my time to her.
Thank you, Katerina. So we'll be looking to receive your written comments on medical debt.
Sure.
And Katerina, can you just identify your affiliation, please?
Oh, I'm sorry. Yes, Katerina Lamarche from the Washington State Hospital Association.
Okay, great. Thanks. Well, that way staff just be certain to note that. And go ahead. Who's next? Krista Abel.
Good afternoon, everyone, and thank you so much for giving me the opportunity to speak today. My name is Krista Abel, and I'm a director at Virginia Mason Franciscan Health. I joined the Healthcare Cost Transparency Board Advisory Committee on Data Issues in April 2023. It was last year, and I took someone else's place. I did submit a comment letter as requested by March 29th, but it didn't make it into the board packet, so I really appreciate this time. I was very interested in the on-point cost growth driver study information that was provided, and this was the basic information provided to the committee to review and understand cost trends and drivers. It was very interesting to me as someone that's worked for hospital systems over the last couple of decades that when you actually looked at the information and I drilled in, the average annual cost increases that are attributed to hospital commercial allowed spend was less than 2%, much less than what the inflation was during that time period. So I was so surprised when the board retreat was focused on priorities that are all focused on hospital spend, when in fact that driver study indicated that that wasn't a significant cost driver for that time period. I'm worried that the true cost drivers, which are utilization, pharmacy, non-commercial product increases that are absolutely not impacted by hospital negotiation or hospital contract language are not the focus of this board. The administrative burden, which is a leading cost driver, and it's an opportunity as focused on in the McKinsey report and as presented to Universal Healthcare Commission, is not the focus. And so I was surprised about what these cost growth policies are going to be focused on. When it comes to rate setting and price growth caps, again, surprised why this would be the focused area when the hospital commercial allowed spend was less than 2% over a 4-year period of time. In regards to mergers and acquisitions, yes, there's been mergers and acquisitions over the last several years. I'm not sure how many more are left out there because these are hospitals that weren't able to survive on their own. And so I'm not sure that's a huge opportunity. And again, I'm worried that the majority of the spend, 75% of the spend, is not commercial hospital increases. It's all the rest of the stuff that could be impacted by significant work by this board and by the committees. As far as the anti-competitive clauses and other language that have been referenced in the AGO study, I'm not sure, I'm not familiar with that language, and I've been a hospital contractor for 2 large health systems. And so I asked for examples of that language in Washington State, because I haven't frankly seen that language. The bottom line is that based on the on-point cost growth driver study that was supposed to inform this committee, our committee and this board, has indicated there's other areas to focus on, and those focus policies that were voted on in a board retreat, from my perspective, will do very little to support material change in healthcare costs that are really needed for Washington State residents. Further, the true cost drivers, utilization, pharmacy, Medicare, Medicaid, and all the other spend is not going to be a focus over the next year or however much time it's going to take to impact healthcare cost spend, which I personally care about a lot. Thank you.
Thank you for those comments. Mandy, I would ask that staff come back to the next at the next board meeting with further information about the utilization. I think we have some more hospital data being presented, so maybe we can ask staff to just follow up with details, and we'll probe into those questions.
I'd be happy to do that. I did have one more public commenter, Sam Hatzenbeller. And I'm sorry, Sam, if I got that wrong.
No, close enough. Thank you. Good afternoon, and thank you, Chair Birch, members of the board and staff. I'm Sam Hatzenbeeler, Senior Policy Associate with the Economic Opportunity Institute, which is a statewide policy think tank working to build an economy that works for everyone. I also co-founded the Fair Health Prices Washington campaign, which is a coalition of patient advocates, labor unions, and business owners concerned about rising healthcare prices. I thank the board for your continued work on tackling our state's healthcare affordability crisis and for prioritizing the pressing topic of medical debt today. Many factors contribute to medical debt: unchecked consolidations, as Adam spoke to, wages that can't keep up with skyrocketing prices, rising premiums, and inadequate coverage. In response to earlier comment from the gentleman from the Medical Association, I would note that near the top relative to other states is not actually a success metric that we want to shoot for. What matters is whether people can actually afford their care, and unfortunately they cannot. As we've shared with the board previously, Fair Health Prices partnered with the Altarum Institute in 2022 to uncover patient affordability challenges. And the survey, which polled 1,300 Washington residents, found that underinsurance was a significant problem. And as you know, underinsurance is when you have health insurance, but you can't afford to use it due to high out-of-pocket costs like coinsurance and deductibles. Our survey found that 62% of residents experienced one or more healthcare affordability challenges in the previous 12 months. And 4 in 5 respondents were worried about affording some aspect of healthcare at the time of the survey or in the future. These numbers were even worse for respondents of color. You've heard this data from us before when we presented a year and a half ago when it was fresh, but it's still just as pressing today. We are pleased with the recent passage of House Bill 1508 that creates the opportunity for this board to take on reviewing this underinsurance and patient affordability data biennially. We're pleased about that. I know you're jumping into that today in this meeting. I am very proud to live in a state that has taken excellent steps forward to addressing rising healthcare prices, including the creation of a public option with expanded subsidies, our new Apple Health expansion program to ensure equity for undocumented immigrants, and banning surprise medical bills, among many other things. But as you know, there is so much more to do. I do applaud and support the direction of the recent February retreat from your board, where you voted to investigate solutions such as restricting anti-competitive contracting practices, addressing consolidation and private equity acquisitions, and price caps and rate setting. These are precisely the tools that will allow us as a state to drive down spending and ensure our healthcare system protects those it was created to serve, the patients. Thank you.
Thank you for those comments. I believe that ends our public comment period. I'd like to make up some time and quickly move on to Evan Klein and Jane Beyer. They're going to provide us a legislative update, wrapping up the legislative session with a focus on the bills impacting healthcare affordability. And I'm going to ask you guys to keep moving quickly.
Absolutely. And happy to go ahead and get started. I recognize that I think the appetizer today. So we can walk through some of this quickly. And what I'm going to do is actually go a little off script here. And Rochelle, actually, if it's easier to not load the PowerPoint or to step aside from it. I know that you have some materials in your packet that focus on a number of the bills and budget items that passed this legislative session, as well as some that didn't but were debated, which I think is a good highlight and overview of those policies that the legislature focused on that are really close to the work that you're doing here at the cost board. But I'll just provide a little flavor, and that is, I think we often hear that there's a need to look broadly at the healthcare delivery system when we think about cost and access related challenges. And I will say, to me, it seems like the legislature has taken that approach over the past several years, including this year. So we saw a debate on policies impacting health plans, impacting pharmacy and pharmacy benefit managers, impacting providers and provider rates, as well as health equity, behavioral health, kind of across the board, and thinking about the suite of work that we do here at HCA, but also with some of our sister agencies. In terms of what passed this session, there were comprehensive pieces of legislation enacted around PBM reform, so some regulatory reform that Jane will talk to, that the Office of the Insurance Commissioner is tasked with kind of implementing, but impacts purchasing and our work here at the Healthcare Authority. A couple of incremental policies focused on out-of-pocket expenditure for consumers, high priority services where we want to ensure access and affordability of that access, including EpiPens and inhalers, so capping the out-of-pocket cost for those to pharmaceuticals. And that is really in line with some of the state's other work in spaces like insulin, where over the past couple of years, the legislature has tackled out-of-pocket expense for insulin and capping that akin to what's happening at the federal level. There was kind of follow-up legislation to some of the major balance billing reforms that the state has taken on around ground ambulance services that Jane will also cover, that the Office of the Insurance Commissioner is going to be implementing, but impacts, it has an impact on medical debt. I think it's a really nice nexus to some of the conversation about what's happening with consumers and the costs that they face out of pocket when they access the delivery system. And then around preserving coverage for preventive services without cost sharing, really just ensuring that some of our state statutes are keeping up with what has been happening at the federal level over the past couple of years. Maybe one of the bigger stories this session, though, is kind of what was discussed but failed. And really, I tee this up as what we expect the legislature to continue to bite off over the next couple of years. And we know that this is not an issue specific to Washington State. These are kind of big national topics: mergers and acquisitions, provider rates, general affordability and contracting practices that relate to affordability. And so we saw these kind of three major policies picked up, debated by the legislature, in some respects advanced through their kind of chamber of origin, and modified throughout that process, but inevitably failing. I do expect that all of these are going to be picked up in some fashion as we proceed to next legislative session. I know that the board has taken on some of this work. So to keep our CARE Act, right, a kind of foundational policy reform around mergers and acquisitions in the healthcare space in Washington. And we know that that's going to continue to be a topic of conversation as we move throughout the summer and into the next legislative session. Covered lives assessment. This was focused on rate increases for providers in the Medicaid space. It really forced us all to think about, what are adequate rates for providers? Where do we need to invest in the delivery system? And where is payment appropriate today? And then as was referenced through some of the public comment conversations around anti-competitive contracting, again, kind of tangential to the mergers and acquisitions conversations, but really this focus on how do we ensure there's appropriate leverage in contracting between providers, facilities, health systems, and health insurers who are trying to build their networks and do so in a way that their enrollees can afford the coverage that they're going to get. Next slide. A number of items as well that kind of came through the budget in this space that I'll just quickly highlight. Apple Health expansion. We talked about that this with the board in the past, but this is coverage expansion, Medicaid lookalike for immigrants who previously lacked access. First barrier, I think, to entry in talking about how you can reduce the out-of-pocket costs for somebody is obviously enrolling them in insurance. And these are individuals who are low income, adults who otherwise lack access to health insurance because of their immigration status. We're excited to be standing this program up in July. We were really excited to see the legislature invest additional dollars in it this legislative session. We got some funding for our PEP-SEP programs. There was also some funding to begin work around essential health worker coverage options, focused on skilled nursing facility employees, but also looking more broadly at other types of kind of critical providers in the state that are in need of more affordable healthcare. And that's work that we're going to be doing in partnership with the Office of the Insurance Commissioner and Department of Social and Health Services over the next year plus. Next slide. I won't spend much time here, but we know IT impacts efficiencies in the system, and that there are some critical investments that we see in IT that we think will help broaden access and make it easier for consumers to access the system, but hopefully also make it more efficient to deliver high quality care. So just highlighted those for a second. And then my last slide here, just kind of wrapping up some of the items from session, were these pieces around rates. We do see the legislature year over year target investments in really highly needed and critical services. So we have seen investment in the delivery system. A lot of these are through the Medicaid program, but thinking about access for tribal enrollees, non-emergency medical transport, inpatient rates, maternity access. These were all policies that the legislature took on this session. It was a short session, only 60 days. So we didn't see some of the large scale investments or reforms that we might otherwise see in a long legislative session. We will hopefully see some of that action next year, but definitely some incremental policies and investments here. So I'll turn it over to Jane because I know she's going to fill in the blanks with some of the commercial insurance work that took place as well.
So I would say for a short 60-day session, there were some pretty significant things that happened. And the agencies were kept really, really busy keeping up with them. So focusing on the ones that affect affordability or that have innovations around rate setting or administrative simplification. Evan mentioned, and I'm sorry, I don't have slides. Evan mentioned ground ambulance balance billing. That was the final puzzle piece to protect consumers from surprise bills And that legislation did pass. I always like to tell people that we have 39 counties in Washington state and 300 EMS systems that provide ground transport. So a very complicated system where public and private providers partner to get folks the emergency services that they need. So the bill, what's significant in terms of affordability, the bill basically bans balance billing for covered ground ambulance services, whether they're emergency or non-emergency, whether they're provided by a public provider or a private provider. And significantly, it departs from the way we've approached balance billing in the past by saying, we're not going to ask the fire department to wheel it, go through arbitration. We're going to set a rate in statute for out-of-network ambulance providers. Not surprisingly, that was the most controversial component of the bill. And it does set a rate formula in statute that relies heavily on the rates that the local jurisdictions set for their services. But I think the legislature wisely said, you know what we're going to do? We're going to have this rate. So this is like an experiment in rate setting. And we are going to sunset it on December 31st, 2027, and have the Office of the Insurance Commissioner come back in the fall of 26 and say, what have we seen? What happened? Did rates go up? What happened to allowed amounts? Just to really what happened to the impact on consumers and cost sharing. And then we have required now that when somebody's in a behavioral health crisis, if they need an ambulance to take them to a behavioral health crisis facility, that gets covered. So it's not just transporting people to the emergency room. And then we have a federal advisory committee report that we're weighing out on ground ambulance. So we're one of 15 states that said, thank you, but we're not going to wait for the federal government to act on that issue. So PBMs, a lot of references have been made to prescription drugs driving healthcare costs. So the legislature, after 7 years of trying, passed a bill to regulate some pretty core PBM business practices. And in terms of access to care, the main thing that will happen beginning in 2026 is prohibit spread pricing by PBMs, which is when the PBM charges the health insurer more than what they pay the pharmacy. And our state employee programs already prohibit spread pricing in their contracts. So now commercial health plans will follow along with that. And then there's been a lot of controversy about the use of PBM-owned mail order pharmacies and keeping small independent pharmacies, especially in rural communities, alive. And so PBMs are not going to be able to require that somebody use a pharmacy, a mail order pharmacy. They can still have lower cost sharing for mail order drugs, but like the number of fills, the days filled have to be the same. Any kind of utilization review or utilization management that's used has to be the same. So it's trying to even up the playing field a little bit more between independent pharmacies and the pharmacies that the PBMs own. And then as Evan indicated, consumers are now going to be protected from cost sharing for all preventive services as they get updated by the federal government, regardless of what happens with the Braidwood decision. And then I did want to mention one bill on administrative simplification, because we know the commission is going to be looking at this. But the legislature did, and this is pretty significant, the legislature passed a bill that said for residential treatment for substance use disorder, here's what the clinical criteria are. It's the ASAM clinical criteria. And when you grant authorization, the first period of authorization has to be at least 15 days. So you get rid of that choppy, like we'll give you 3 days and another 3 days and another 3 days. And then equally important, it requires that the healthcare authority and OIC develop a whole single common process for how that prior authorization process looks, so that you don't have different health insurers requiring different things to give prior auth. So those are the main things that touch on the issues that the board or the commission are going to be looking at this year.
Great, thank you to both of you. Jill, do you want to take us into 1508 real quickly?
Yep. Okay, so I'm going to do a quick overview. These are some of the changes that will go into effect with the passing of House Bill 1508. So committee expansion of potential cost driver analysis, 2 biannual surveys, changes to legislative report timing, public hearing on healthcare cost growth report, and best practice analysis. So the committee expansion, what was formerly known as the Advisory Committee of Providers and Carriers will change to Healthcare Stakeholder Advisory Committee. The members will be expanding here, as you can see, at least 2 members representing the interests of consumers, at least 2 members representing the interests of labor purchasers, and at least 2, including at least 1 small business representative. So this provides the voice, as we heard earlier on one of the public comments, for consumers and purchasers as well as patients here in Washington. Expansion of potential cost driver analysis. So as also indicated in one of the comments during public comment, we will be able to, or the board will be able to share data sources moving forward. Under Title 48 RCW, they will be able to share health data information with Department of Health, Health Benefit Exchange, the Healthcare Authority Prescription Drug Reporting, Washington State All-Payer Claims Database, Prescription Drug Affordability Board, and the board may also share its data with Prescription Drug Affordability Board and any healthcare cost analysis efforts conducted by the state. The 2 biannual surveys that will be taking place, the first surveys will be due by December 1st, 2025. The first is the underinsurance among Washington residents, and the second is insurance trends among employers and employees. Changes to legislative report timing. As you know, the legislative report was previously due August 1st, and that is going to be pushed back to December 1st is the due date now for the legislative report. There are new public hearing requirements. The board will hold an annual public hearing. The first hearing will be no later than December 1st, 2024. The hearing must include discussion on growth in total healthcare expenditures in relation to healthcare cost, growth benchmark performance, and provider groups with fewer than 10,000 unique contributed lives shall be exempt from identification. The agenda and materials for this hearing must be made available to the public at least 14 days prior to the hearing. Best practices analysis. The board shall study regulatory approaches, best practices from other states, and the study, as well as any recommendation for changes to the board arising from this study, must be submitted to the board as part of the annual report by December 1st, 2024. That is all.
Thank you. Rochelle, thank you, Evan, Jane, for catching us up a bit on time. Are there any questions from board members on the presentation? All right. Well, with that, I would like to move us to our kind of main event here, and it's really my pleasure to welcome Noam Levy. Noam is a renowned healthcare journalist, and he is a senior correspondent with the KFF Health News, formerly known as Kaiser Health News. I probably don't need to tell you too much about Noam, but he has achieved many accomplishments in his field, including the prestigious Nickham Award for his 2019 series, Inside America's High Deductible Revolution. He's been published in JAMA, Health Affairs, Millbank Quarterly. He's even been on TV some, because I saw him years ago. And he's going to engage with us today about his recent investigation into medical debt in America. And please join me in welcoming Noam. So thank you so much for coming to see us.
Thank you.
And don't worry about time, because we're going to make it up. So you've got a full hour.
Okay. Well, thank you. Thanks for that nice introduction, and thank you for having me here at the board. I'm a former State House reporter in California and Minnesota, and so I love state capitals, and it's really just a pleasure to be here with you and be able to share our work, even if it's maybe not going to be all that uplifting. I'm going to talk to you a little bit today about the project that we've been doing in collaboration with NPR and CBS News about the scale of medical debt in America. And I've been covering healthcare for about 15 years, most of it when I was with the Los Angeles Times. And this work really kind of grew out of covering healthcare across America, interviewing hundreds and hundreds of patients and visiting hospitals and doctors' offices, and sort of coming to the conclusion that this problem with medical debt was a kind of crisis that was hiding in plain sight. And I'm afraid to say that one of my takeaways from spending as much time as I have all over this country and looking at healthcare is that this is arguably the defining feature now of our healthcare system. We found that 100 million people in this country have some form of healthcare debt. And I don't think it's an overstatement to say that, frankly, our healthcare system is now creating medical debt on an industrial scale. So I'm going to tell you a little bit about our findings. I'll talk through a little bit kind of how this problem is being fed by our healthcare system, how it's distorting our healthcare system, and then at the end, walk you through a few of the policy levers that that folks that I think states are experimenting with, among them Washington State. So I'm going to start with a story. So actually, can you go back one slide? Because I'm a journalist, and one of the things we do is tell stories. I want to tell you a story about one of the hundreds of people who we met as in the course of our reporting. This is Allie Ward, and Allie is a nurse. She works in NICU in Chicago Hospital in Chicago. Her husband is runs a small nonprofit. They're in their mid-40s. They're pretty solidly middle class, and they have two boys, twins, who are I think now 12 years old. And when they were born, Allie and her husband were afraid they were going to end up on the streets because of the medical bills they received. So Allie was working at the time at a hospital in Dallas. And unfortunately, her boys were born a little bit early, and they ended up having to go to the NICU. One of them had to have emergency surgery to have a trachea enlarged. And as you can imagine, the bills were pretty substantial, even though both she and her husband had health insurance. And by the time it was all over, the family had $80,000 bills that were not covered for one reason or another. Allie and her husband had to move back home to be closer to friends and family who could take care, who could help them. They loaded up their credit cards. Allie, even though she was a new mom, had to take on extra work, and she worked night shifts and day shifts in order to pay the bills. She said she was literally afraid that they were going to be homeless. She said, among other things, I wanted to be a mom, but we had to have the money. Next slide, please. Allie is just one of literally, as I said, hundreds of people who we interviewed across the country whose lives have been turned upside down as a result of medical debt. In the middle there on the left, you can see Jenny Ray Peters with one of her daughters. She's a foster mom in Rapid City, South Dakota. She was diagnosed with breast cancer and was contacted by debt collectors literally as she was in the recovery room from a double mastectomy. Edie Adams, that's her on the right there. She only owed about $131 from a rape exam that happened after she was sexually assaulted as a student in Chicago. She's studying to be a doctor now. And as some of you may know, many states prohibit patients from being billed for these kinds of exams. But there was a mistake, and she was contacted by a debt collector. She tried to explain this mistake. The debt collector said, okay, sure, I'll put that in the record. But she couldn't get it taken off because the medical practice that had generated the bill was no longer a business. And she continued to get calls for 5 or 6 years, every 6 or 9 months, because the debt kept getting sold, and she had to keep explaining to people that this was not a legitimate debt. She said she was basically haunted by the worst day of her life every 6 to 9 months by a debt collector. Down there on the bottom right is Cindy Powers. She's in her early 50s. She and her husband live outside of Denver, but they also lived in Texas before. And when she had to have 19 surgeries as a result of a very unusual twisted intestine, they ran up $250,000 medical bills. They ended up losing their house. They had to declare bankruptcy, and they moved back to Colorado, where she's from. Next slide, please. So when we think about medical debt in this country, traditionally, medical debt has been measured as the share of people who have a medical bill on their credit report that they haven't paid and has been reported to one of the major credit rating agencies. But one of the things that we discovered is that this vastly undercounts the amount of debt that exists out there. And so we did a poll with our polling and survey arm at KFF to kind of dig down into how big is this problem? Where really is it? And if you look at this, what you see is that it is not just medical bills that people don't pay that are medical debt. Many people put their medical bills or their dental bills on credit cards. And then they don't pay the credit card and it stays on their statement and it may get carried on for months or years. That's not measured as medical debt on a credit score. It's going to be credit card debt, but it is medical it's generating. People take out loans from banks, or they take out another mortgage, or maybe in the worst case, they go and do a payday loan. That is not recorded as medical debt. That's a financial product. Or they borrow from friends and family. These are informal arrangements, which, as you may know, can sometimes be repaid, sometimes they can't. In many cases, they create a whole strange dynamic in families if one family member or friend is paying for somebody else's medical bills. Or people go on payment plans. Increasingly popular both in the hospitals, but now in the outpatient setting as well, where someone is paying off a bill over 2 or 3 years, maybe it's $100 a month or what have you. That also is not going to be recorded as medical debt on a credit report. You are functionally in debt the same way you would be if you were paying on an installment plan for a television or a new car. And when you put all of that together, you get 41% of US adults have some form of healthcare debt. That's 100 million people. Currently, you ask about what the situation is over the last 5 years, 57%. So more than half of the people in the United States have been forced to go into debt at one point or another. Next slide, please. So how much are we talking about here? Well, some of the debt is relatively small. A third of people owe less than $1,000. But as you'll see, quite a number of people owe a lot of money. 1 in 8 owe more than $10,000. And fully 20% of people say they don't expect to ever be able to pay off what they owe. Next slide, please. Medical debt is everywhere in America, but it is not evenly distributed. You'll see, as one of the speakers noted earlier, Washington does do better than most. This is, however, is only, I should say, a measure of medical debt on credit scores. This is data from the Urban Institute, which analyzed a data set from, I think, TransUnion or one of the major credit reporting agencies. Not surprisingly, medical debt is heavily concentrated in the South and Appalachia. These are poorer parts of the country, of course. They are also places that don't have the robust insurance protections that a place like Washington or Minnesota has. But when we worked with the Urban Institute to analyze what was the #1 predictor of medical debt at the county level, so in other words, if you looked at the counties that have the highest level of medical debt, what is the best predictor? It's not poverty, it's not race, it's not insurance coverage, it's chronic disease burden. So the places where people are the sickest are the places where they are most likely to be in debt, which of course stands to reason, but if you just step back and think for a moment about the perversity of a situation in which people who are the sickest and are dealing with all the burdens associated with a chronic illness like cancer or diabetes or heart disease, layered on top of that now is the financial insecurity that comes from being forced into debt. Next slide, please. The impact of this medical debt is something that we gathered anecdotally, but we also asked about in our survey. And what you find when you look at this data is that more than half of Americans who have been forced to go into debt say that they've had to make a difficult sacrifice as a result of that debt. 2/3 have cut spending on food, clothing, and other basics. 2 in 5 have had to take on extra work like Allie Ward did. 1 in 5 have been forced to change their living situation. Maybe they've lost a house, or maybe they've been forced to move in with friends or family. We interviewed many young people who were forced to move back home because of large medical debts that they incurred if they got sick. And I think really one of the most troubling findings, 1 in 8 say that they had actually been denied medical care by a provider because of outstanding medical bills. I want to say one thing really quickly about the top finding here. So there's been a lot of discussion. I'm sure you have heard it here in the state capitol. Maybe you've talked about it in the authority, about social determinants of health, about how having access to adequate nutrition and housing is as consequential as anything that may happen in a doctor's office. All of which is true. Many health systems, many physicians talk, as they rightly should, about concern about addressing these underlying social determinants. And yet medical bills being generated by this system are making it harder for people to get the food that they need and the shelter that they need. The very same social determinants that at the same time the healthcare system is talking about how they're concerned about how that may impact the course of their disease. Next slide, please. We also know, as was mentioned earlier, that people are just skipping care. They're not going to the doctor because they're afraid of going into debt. This is from another survey that KFF did about how many people are actually skipping care or putting it off. And when you see 43% are putting off or postponing getting healthcare because of cost, you can understand that there's a problem. Next slide, please. Medical debt really reaches up into the highest income strata in the United States, which is a remarkable thing, because when you look at households making more than $90,000 a year, close to half of that population records that they have had some kind of medical debt. Most people who have medical debt have health insurance. But it is also a problem that disproportionately affects vulnerable populations. Black Americans are 50% more likely to go into debt. Young people are more likely to go into debt. In many cases, young people, as you probably know, are less likely to have really robust insurance plans. Sick Americans, as we talked about, low-income Americans are particularly prone to going into debt. And parents. I'm finishing up a story right now about the particular burden that medical debt puts on new parents, because our poll showed that 1 in 5 people who go into debt attribute at least part of that debt to childbirth. And so when you think again about broader questions about what we as a society are doing, we already know that anyone who's had kids knows that it's really, really a shock when your baby comes home and all of a sudden you're buying formula and Pampers and all the other things that you have to get. Well, increasingly, new parents are also contending with thousands of dollars medical debt. Next slide, please. I want to pause, though, to drill down on one particular part of the disparity story in healthcare debt, and that has to do with racial disparity. Because one of the striking things that we found when we looked at it was the concentration of medical debt in communities in this country of color. And I'm going to sort of illustrate just how big the racial gap is in medical debt. I'm going to tell you a story about Knoxville, Tennessee. So this is a map of Knox County. Knoxville, if you've never been there, is a kind of medium-sized city in the eastern part of Tennessee, near the Oak Ridge Labs, which were big in the Manhattan Project. Traditionally, it was a segregated town, like many. And if you look here at the map on the left of zip codes, you'll see this pattern of residential segregation that persists in Knoxville as it does in many communities. And if you look on the right, the share of people in these zip codes who have a medical bill that's on their credit score, you can see that there's an overlap there. And one of the interesting things about what happened in Knoxville, if you look at the history of the community, is that the Black community in Knoxville has long been concentrated on the east side downtown, where you can see on the left-hand side map there. And this was traditionally the poorer part of Knoxville. But in the early part of the 20th century, it was actually a place where the community was relatively vibrant economically. There was a lot of business, there were cinemas, there were a lot of churches. And the first Black millionaire in Tennessee lived on the east side of Knoxville. And then after the Second World War, in the wave of urban renewal that many cities underwent, Knoxville's city fathers put a freeway right through the middle of that community, decimated. More than 500 homes were torn down, several dozen churches. The Black business district was gone, movie theaters, everything. And the community never really recovered. Today, if you go there, it's still empty lots. There are parking lots where they built sort of civic centers, these sorts of things. And what wealth existed there completely disappeared. And if you think about what medical debt does, medical debt is a function of not having wealth. If you don't have wealth, you can't pay a large medical bill. They come. You don't have any savings. You don't have any property value. You may not have retirement accounts. And if you get that kind of bill, you're less likely to go to the doctor. If you don't go to the doctor, you get sicker. You may not be able to work. If your credit has been affected by going into debt because of medical bills, it may be more difficult to get a job. And so you can see how medical debt can reinforce the lack of wealth. A lack of wealth that in Knoxville's case, and in many cases, many communities across the country, a lack of wealth whose roots go back to a really ugly history of racial discrimination in housing, urban development, jobs in this country. And we could look at any community in this country and see a similar kind of pattern. One of the most striking statistics that I learned researching medical that actually has nothing to do with healthcare. It has to do with wealth. And if you look, the Federal Reserve measures wealth every year in a survey that it does. And nationally, the median white family in the United States has $184,000 in assets, housing, savings, et cetera. $184,000. The median Black family, $23,000. There's an enormous wealth gap, and the healthcare system is exacerbated. Next slide, please. So, what's going on here? Let me spend a few minutes talking a little bit about kind of some forces that are driving this problem. Next slide, please. So part of what's happening, of course, at the sort of very most basic level, is that there's a debt collection machine that is now part of the American healthcare system. We looked at debt collection practices at a sample of about 500 hospitals across the United States. There are about 5,000, so this is about a 10% sample, a random sample, big, small, rural, critical access, major systems, et cetera. We looked at the policies that they have for how they bill and collect their patients. We found that 2/3 have policies that allow them to sue patients or take other legal action against people who don't pay, garnishing wages, placing liens on property. Not all of them do it. Some of them will say we haven't done it in a couple of years, but the policy is there, and some of them stop and then they come back and do it again. We found 2/3 report people to credit bureaus, so dinging people's credit scores, making it harder for people to get jobs, rent apartments, get cars. 1/4 will sell the debt to other debt buyers, like what happened to E.D. Adams, who I was telling you about. And 1 in 5 will deny non-emergency care to people who have outstanding bills. Next slide, please. But the bigger problem here, as has been alluded to, is that everybody insured, including people with commercial health insurance, are increasingly not sufficiently protected by the insurance that they have. And this is directly a function of this sort of quiet but really profound change that's happened to health insurance in the United States over the last 20 years. And that's the rise of high deductible health insurance. So if you look, this is again data from KFF, my colleagues at KFF, which is an employer survey, which you guys are probably very well aware of, that looks at the share of people, of workers in a health plan with a deductible of $2,000 or more. If you look back to 2009, it was a pretty small share, right? All firms 7%. Now it's close to 1/3. And as you know, many people are in plans with $10,000. And when you look at the share of people in this country who don't have $500 to cover an emergency bill of any kind, it's like 40–50%. You don't need a Nobel Prize in economics to realize that there's going to be a problem. People don't have savings. They're in health plans that, if they get sick, are not going to cover thousands of dollars of their medical bills, they're gonna end up in debt. So it's a pretty simple problem. Next slide. What's standing in the way of addressing this, I would argue, is that we have a imbalance in terms of whose problem this really is. I've just been telling you about all the horrible things that people in this country are experiencing when they get large medical bills. Let's look for a minute at what's happening in the healthcare system itself. And I want to preface this by saying, I want to be clear that it's obviously difficult for anyone who works in the healthcare industry if people are not paying their bills. It's hard for hospitals, it's hard for doctors, it's particularly hard for small practitioners, hard for everybody. But the healthcare industry in this country has, in many respects, figured out a way to work around that. And they've created models that essentially allow them to keep the lights on, even though increasing numbers of their patients aren't paying what the bills that they get. These are the profits of the large for-profit health insurance companies. They're doing just fine. And probably won't be surprising to you that United Health is reporting profits of the billions of dollars. Let's look at hospitals. Next slide, please. I'm sorry, but this is the patient financing industry. So while patients are suffering from bills they can't pay, this is an economic opportunity for some. And what we've seen happening around the country increasingly is that lenders, oftentimes backed by private equity, are entering into this space to finance medical bills for providers. So hospitals will contract with a third-party financing company to handle the payment plans. Oftentimes, these plans come with interest, which can add large amounts onto thousands of dollars. Most hospitals, I will say, don't get attached interest to their payment plans, but there's a recent study suggested as many as 10%. Next, please.
How frequent is, when you said you looked at like the sample of 500 hospitals, or how common is it for hospitals to contract with outside entities for healthcare financing?
I wish I could answer that. I can't, we didn't, that was not a question that we looked at. There was just a study in JAMA, I think, by some researchers who looked at how frequently hospitals are attaching interest to, and they found about 10% charge interest. But there are some that will contract and won't charge interest, and there's also some that don't contract but will charge interest. So it really varies. And some change. Some will have done it and they will stop doing it, and some are going. It's more common in the outpatient settings, oftentimes, in certain disciplines. So for example, Care Credit, who some of you may have heard of, is the market leader in terms of financing medical care for consumers. They're very heavily represented in dental practices and in certain kinds of specialties that have historically been elective. So like cosmetic, but increasingly so that, and what their product is primarily a deferred interest product where, if you make your payments, you pay off within 24 months, there's no interest. After 2 years, the interest jumps to like 29%, 30%. And regulate the CFPB and others have sort of historically taken a pretty dim view because a lot of times people don't understand what they're getting into, and their providers push these products on them. Next slide, please. Hospitals as well have learned to adjust. Now, it's no secret that hospitals' margins have been under pressure. I know the largest hospital system in Washington State, I think has recorded some losses in the last year. Hospital margins traditionally are not as large as they are in the pharmaceutical industry. But when you look at what's happening, large hospital systems have been able to stay in the black. Even though, as I said, they're not getting paid. We looked at the margins around the major hospital systems in the Dallas-Fort Worth area. And Dallas-Fort Worth has the highest debt burden of any large metropolitan area in the United States. Obviously not a Medicaid expansion state. These were the margins for these major systems. Cook Children's recorded a double-digit margin. Baylor Scott and White, 7%, Texas Health, 5.9%. These were larger margins than all but 2 of the like 20 Fortune 500 companies in the Dallas-Fort Worth area. Like bigger than American Airlines, AT&T, you name it, they had bigger margins. Next slide, please. So what do we do with all this information? I want to leave you with a little bit of hope because there has been a lot of action at the state level around the country to try to think about what are some of the things that can be done to help ameliorate this problem. There's been less action at the federal level, I think for a number of different reasons, not the least of which is, as you may have heard, things aren't working so well in Washington, D.C. and Congress these days. But there are things happening at the state level, including in Washington. And I want to talk briefly about 3 kind of general approaches to sort of thinking about addressing this problem. Next slide, please. The first is, I can't see what that says, but this is the first group is trying to deal with essentially the symptoms of the disease. How can regulators, government, how can better protect people from the worst excesses of debt collection? There are a lot of people out there, patient advocates, who say, in what world is it okay for a not-for-profit hospital system that enjoys enormous tax breaks to take its patients to court? How is that, like, as an absolute question, should that even be allowed? And so, or at the very least, should there be some guardrails around who could be taken to court? Should there be some tests for their income? And so what you're starting to see is some states begin to put some restrictions on these kinds of collection activities. 2 states so far, New York and Colorado, have barred credit reporting for medical debt, which can potentially be hugely consequential for a sector of the population that, you know, needs to be able to rent an apartment, get a job, or get a car. There have been restrictions put on interest being charged on medical debt. One of the earlier guests mentioned 9% interest on a medical debt. Arizona had a citizen-backed initiative 2022 to cap interest rates on medical debt. That's been a place where people have talked about trying to restrict kind of collection activities. And at the national level, the Consumer Financial Protection Bureau, which was the watchdog created after the financial crisis, the leader of the CFPB is a very gung-ho administrator who is, they've done a lot of research showing problems with credit reporting, a lot of inaccuracies in medical bills, people having trouble getting inaccurate bills taken off of credit reports, and CFPB is looking at putting in place a total ban, a national ban. Next slide, please. The second area that folks have been looking at, and Washington State's been very active in this space, is trying to think about strengthening the way that hospitals in particular provide financial assistance to lower income patients. A lot of reporting around the country by journalists has shown that patients that are being targeted in lawsuits and other aggressive collections, in many cases should have qualified for financial aid, but for whatever reason they didn't. The whole discussion around charity care really kind of got supercharged after the Affordable Care Act because the ACA had a relatively underappreciated provision at the time that was designed to make what hospitals were doing more transparent. And so hospitals were sort of forced to, not-for-profit hospitals were forced to publish their financial assistance standards and make them very available for patients. But as part of our surveying work with 500 hospitals, we found this was just, many hospitals were not complying with this. Or they have these incredibly onerous application processes where, for example, people have to report not only their income, but all of their assets, the make, model, and year of their automobile. Do they have any retirement savings? There's a hospital system in Colorado that was requiring people to report any GoFundMe campaigns that they had as an asset that should be counted against their eligibility for financial assistance. And so some states have begun to put more uniform standards around financial assistance, which I think makes a lot of sense given that, you know, if you're a patient and you're going you get in a car accident and the ambulance comes to the intersection and turns left and goes to one hospital instead of turning right and going to another hospital, it could be the difference between you getting financial assistance in one place and in the other place getting sued and having your wages garnished because the standards are so varied. So uniform standards, everybody above 200% of FPL, for example, as Washington has done, or just simplifying the application process. Some states like Colorado have put in place a uniform application, which again, there's probably not, if you talk to people who work in this space, getting all that asset information is not really very useful. A lot of people who work in revenue and hospitals have this fear, have this fear that there's this enormous population of patients out there who are driving around in Ferraris, and then when they come to the hospital, they won't pay the like $500 bill. And unless they force people to apply for these things or force people to put all their assets down, that there's going to be all these freeloaders out there. And in fact, sure, there may be a few people out there whose income is like $15,000 a year, and they have, you know, $500,000 in their 401k, but there's not that many. So that's another area where I think there's opportunities for simplifying it. The challenge is that hospital bills, while large, are not the whole ballgame. And traditionally, the regulatory intervention, at least at the federal level, was limited to not-for-profit hospitals where there's more leverage. States have been a little bit more aggressive. I think Washington standards apply to all hospitals. And so states can do some of that stuff. All right, last one here. Stop. The last bit here is sort of addressing the problem of out-of-pocket burden. Of course, this is like the elephant in the room, that people are ending up in these health insurance plans that they can't afford, essentially. And so one way, of course, to address this is to simply cap what people have to pay. And I would add that this is the way that other wealthy countries address this issue. And I'm not talking about Canada and the UK with socialized systems. If you go to Germany, as we did as part of this project, a country that has what we would consider private health insurance plans, but highly regulated, out-of-pocket costs are strictly regulated and standardized. It's 10 euros to go fill a prescription. It's 10 euros a day at the hospital. It's zero cost sharing at the primary care, no matter which plan you have. And everybody knows that. Now, there's a lot of back office stuff that makes that possible, which I know is what you guys work on. But I think I'm encouraged to some extent that there is some discussion at least about putting in some caps in what patients have to pay. The ACA included an out-of-pocket maximum, as you know, but it's just too high. $8,000, $9,000 is more than most people can afford. And because of network challenges, there's always bills that are getting out of network. And even with the No Surprises Act, there are still big bills. So among the things that have been talked about are exempting some things from deductibles. You know, some states, maybe Washington done this, I think California has done this with the benefit with the exchange plans. There's talk about should certain kinds of services be exempted. Preventive services were obviously exempted from cost sharing in the ACA. Massachusetts is talking about childbirth. To my point earlier about that big event, there have been talks about cancer because of the incredible burden that cancer, another chronic disease. But all of this, of course, requires larger discussions about controlling underlying prices, which I know is what you are focused on. But I think, frankly, until the out-of-pocket experience of patients is addressed, all that other stuff isn't gonna matter. People are still gonna go into debt. So till people don't have $2,000 or $3,000 or $4,000 bills, people are gonna go into debt. So I have one final warning and then I'm really done. Sorry, next slide. And that is just to say that this is a difficult problem to address because it has many fathers, many mothers. Everybody has responsibility for it. It's easy to point fingers and say it's the hospitals or the insurers or the drug companies or the doctors or the employers who are providing these health plans. And I just want to issue a final warning, since members of this board I know work for very important employers, that historically, I think there was an assumption that workers were generally happy with the benefits that they received, and that surveys showed that people were appreciative of their employer coverage. It generally ranked pretty high. But that is changing. It's changing. Next slide, please. This is again other KFF polling work that we've done. When you ask people about how worried they are about their out-of-pocket costs, ESI employers coverage there in the middle is not that much different than marketplace coverage. And it's way worse than the public. And that, I think, is a recipe for trouble, because people historically may have been grateful, but I'm not sure how much longer. And so hopefully nothing else I tell you is lights a fire. Hopefully that. I'll stop there. Thank you all very much.
Thank you so much for that insightful presentation. We have a few minutes. Do any board members want to ask Noam questions?
So just one thing to note, our agency actually was directed by the legislature to do a study about options to reduce cost sharing for childbirth, for prenatal care and delivery. So we're doing that now, and the results are due back to the legislature on July 1.
Oh, cool.
So we'll see if anything happens there. And we've been paying special attention to it, given how horrible the health disparities are on maternal mortality.
Thank you for that update, Lois, and then we'll go to Margaret on the screen.
What can we do to address the large disparity between the large and small firm deductibles? Any thoughts, any ideas? I run a small business, and just 2 employees, my husband and I. The insurance for my husband and I now is $28,000 a year. And we take it, we take it very seriously. We want our employees to have insurance that allows them to have coverage. So we always do a gold or a platinum plan. We've added HRAs so that it'll cover their deductibles and that kind of thing. But most people in our business, in our type situation, can't afford that. I mean, I know people that run businesses like mine that don't even have insurance themselves. So
well, I think the answer to that is exceeding my brief. I mean, I from my perspective, it's cockamamie that there should be a difference between, whether you work at a firm of 5 employees or 500 employees. Why should there be a difference in the kind of protection you get? But that's the system we have.
it was so big until I saw that.
Thank you for that question. Margaret, you're up next.
Well, thank you. I'd like to better understand the causes of the medical debt. In addition to high deductible and coinsurance and high out-of-pocket maximum, is it caused in part by people going uninsured, and also how about going to a non-preferred provider? I'm curious about this couple with the premature twins, and with them both having insurance, how could the bill get so high? Just doesn't seem to make sense to me.
So on the story of that family in Texas, it was a combination of out-of-network providers, and then particularly there ended up being a lot of one of the kids had cerebral palsy, and there were an enormous amount of therapies that were denied, and that contributed to some of it. But to answer your bigger question about kind of what's driving this, so I think historically there was a presumption that a lot of the problem of medical debt was a problem of insurance coverage, that the uninsured were racking up these huge bills, and that was the context in which charity care was talked about and policies were crafted. But most now of the people who have medical debt have health insurance, and so this is no longer a function of not having health insurance, but it is a function of having health insurance, getting sick, and then not being able to afford the out-of-pocket costs. And some of that, yes, is a result of the very, very large bills would be the result of some sort of network issue. But if it's $5,000 or $10,000, that can be a covered set of services. It's just a large amount of bill because it's a family plan with a large out-of-pocket maximum.
Right.
And $10,000 is more than people can afford.
Thank you.
Bianca.
Yeah, thank you so much for this presentation. Very concerning. And I also scanned that New York Times article about, this RAP group that raised a lot of money. I'm curious, you touched briefly about a lot of money to resolve medical debt, for those who don't know about that article. Anyways, but I am curious about the role of crowdfunding. You did mention it briefly, and has that had any measurable impact on medical debt? And then separately, I'm curious what you think about the surprise billing rules, and if that might help mitigate anything in the medical debt space.
Sure. So crowdfunding is a hugely problematic byproduct of this issue. As you may know, GoFundMe, the largest category of fundraisers on GoFundMe is medical. And there's been some really interesting research done actually by a professor at the University of Washington, Bothell, am I pronouncing that right? About the way that crowdfunding deepens disparities, because when people are forced to compete in the marketplace of suffering, essentially, that disproportionately advantages people who are able to present a compelling story of suffering, and people who have a network of people who have the ability to give. And the researchers looked at sort of who was successful and who was unsuccessful on GoFundMe, and patients of color were dramatically less successful. And people who sort of need help with chronic disease, I can't afford my insulin, or I had a diabetic attack and I ended up in the emergency room. Those kinds of stories don't resonate. The middle-class family who has a 5-year-old diagnosed with cancer, like, people write the checks for those kind of families. And so it's hugely problematic. I can't remember your second question. I'm sorry.
It was about surprise billing.
Oh, surprise billing, yeah. So I think it will have an impact. I think there's some indication already that it's more bills than everybody, certainly than CBO thought, are being subjected to the process for adjudicating it. But I think the equally troubling finding from the initial findings, you guys would probably know this far better than I, is that the balances that the arbitration process is finalizing are still pretty big. And so they're not eliminating the bill. I would add there's one final sort of weird twist to the surprise billing story. Next week, I'm going to New Jersey to go visit a family who was served with an arrest warrant on a $14,000 surprise medical bill. because notwithstanding the fact that the law is what it is now, this bill was incurred from an emergency gallbladder surgery 6 years ago. And the emergency physician who was out of network at the local hospital in northern New Jersey not only sued, but then went to court to get an arrest warrant to compel the people to pay. So only in America.
No, this notion that medical debt is crisis hiding in plain sight. It's your presentation is so compelling. I think our board, it gives us kind of a call to action about what policies could we be recommending or pushing forward. So I can't thank you enough for coming and sharing the story. I'm so glad we got you before Oregon. He's headed to Oregon after us. And anything you can do to partner in our state to keep bringing this issue to life, local media, other large employers that want to join our efforts around really broadcasting more of this so more people, and we thank TBW for airing this as well. And I'm sure board members will be bringing this back forward as we have time to reflect on what next to do. So I want to thank you. I think we should give Noam a round of applause. We're your first passport in the country to visit with. See,
Yes, you
so
are.
blazing trails, but really, we so appreciate you. And we have Noam's contact information as if there is our follow-up items. So
Please,
thank you.
don't hesitate. Thank you.
Great. All right. We have some more work to do, so I am going to move us forward. Gary Cohen from HMA is going to help us facilitate further conversation and discussions on this topic in relation to our work plan and the current policies the board has identified for making healthcare costs more transparent and affordable here in Washington State. So if I can direct you to tab 7, Gary's got some HMA slides and the proposed work plan presentation. And Gary, over to you.
Thanks very much, Sue. I think we're gonna spend a few minutes just following up on Noam's presentation, talk a little bit about Washington's policies, and just kind of ask the question whether there's any further policy discussion that the board would like to have on the medical debt issue, and then talk about going back to the policy selections that were made at the retreat, and talk about the sequence of our examination of those policies, going deeper into how they would be carried out, how they would be implemented, and the work plan for 2024. So next slide, please, Rochelle.
Sorry, 1 second, Gary.
Yeah, you're good. Actually, I think you can go 2.
1 second.
Yep.
We had a frozen screen. Imagine that we had a little IT hiccup. Those things happen, don't they? No pressure, Rochelle. Got redundant systems. See them firing up another computer.
Okay, here we go. So next slide. Washington actually has some pretty strong policies to protect people from medical debt. On the next slide, we talk about charity care. So in Washington, at larger hospitals, which collectively have about 80% of the beds in the state, people with income up to the 300% of the federal poverty level are entitled to receive treatment with no out-of-pocket costs, regardless of their insurance or immigration status. And people up to 350% of the federal poverty level are entitled to a 50% discount on those bills, and then up to 400% of FPL are entitled to a 25% discount on bills from those hospitals. The challenge, however, and Noam talked about this some, is whether the people who are entitled to that financial assistance are getting it. And you all may be familiar with the fact that in February, just this past February, the Attorney General reached a settlement with the Providence system over its failure to offer charity care to those entitled to it, and that settlement required $158 million in refunds and debt forgiveness in addition to some fines. So I think there could be more to do to make sure, you know, as Noam talked about, that the applications are simpler, that people are actually getting the financial assistance to which they're entitled under the law. 6 states require hospitals to require a minimum amount of charity care, and Washington does not. So that's an issue that the board could look at and the legislature could look at. Oregon has a formula that looks at the hospital's revenue and operating margin and generates a number of an amount of charity care that the hospital is required to spend. And this issue has come up, and Noam referred to this as well. I think there have been a number of articles that have been written and studies have been written comparing the tax benefit that not-for-profit hospitals get with the charity care that they offer, and asking the question, you know, are they doing enough to justify, given the fact that they're entitled to those tax benefits. Next slide, please. Then with respect to billing and collections practices, there is federal law that requires waiting periods and notification before hospitals implement certain extraordinary collections practices, such as garnishing wages or selling debt to a debt collection agency. Washington requires a waiting period and a screening for eligibility for financial assistance before a hospital can send a bill to collections. And requires a waiting period before medical debt can be sent to a credit reporting agency. But it does not prohibit sending a medical debt to a credit reporting agency, as some states do, and as the Biden administration has proposed, although those regulations have not yet been issued to put that policy into effect. A few states require hospitals to offer a payment plan to low-income and uninsured patients, and that's another policy that Washington does not have. So that's kind of a brief overview of where Washington sits. You know, compared to a number of states, as I said, I think it has some strong protections. There are a few areas that might be considered to beef up that protection.
Thank you, Gary. Greg, you have your hand up. Go ahead. Greg, you're on mute if you.
Sorry, couldn't unmute. Gary, do you know, is there a what is the waiting period in Washington? What's the requirement?
You know, I don't have that specific answer. I can get it and report back out.
Okay, thank you.
Sure, be my pleasure. Any other questions or comments on this? Then we're going to move ahead to talking about the work plan and the work for the remainder of the year.
And I would just ask if Emily Bryce is on. Emily might be able to answer that for us.
We'll need to bring Emily Bryce on back into the.
Ingrid, go ahead.
No, thank you so much. Fantastic presentation. I really like how you had 3 areas for action at the state level. And I think what we just heard from Gary was speaking to one for sure, and sort of 2F3, the rethinking health plan design. So as I run the exchange, I think we have done a deep think between our insurance commissioner, the healthcare authority, on access to care for the deductible, on standardization, on a public option product that involves a reimbursement cap. And those things are all helpful around the edges, and I think help us make progress. But our board, and I report up to a bipartisan board, keep coming back to it's the underlying costs and the rate of increase of overall premiums and subsidization not keeping up. So I just wanted to highlight that as sort of a segue to our conversation, because I think Washington is less worse than other states on medical debt because of what we shared here, as well as I think because of some of the work, the creative work around rethinking health plan design. But we have to do more. So I'm glad you're getting around to all that.
I wish I was actually.
You will be after we break.
Okay.
And thank you for that. And just to follow up real quickly on that, on the plan design issue, which I think is very important. I think it's important to recognize that there's a reason why deductibles and copays have been going up as much as they have in the employer market. It's a shift from the employers paying for the healthcare, shifting more and more of the burden to employees, right? So the employer's paying, most of the premium, but and the effect of having a high deductible plan is that the premiums are lower than they would be if you had a low or no deductible plan. And the effect of that is it's really a cost shift from healthy people to sick people, because if you're healthy and your premiums are lower, you're benefiting from that. But it's when you get sick and you then have to pay out of pocket for your care, that's when the high deductible and the high copays is really having an impact on you. And one of the underlying premises of the Affordable Care Act was that we wanted people not to have to pay more because they're sick. And that's why, pre-existing condition exclusions were done away with, and the ability to uprate and charge people more because they had pre-existing conditions was eliminated under the ACA. But that policy of people not having to pay more just because they're sick is really being undermined now by the fact that we have these high deductible plans and high out-of-pocket maximums, so that when people get sick, that's when they get hit by those costs, right? So I think it's important to, when we talk about plan design and doing away with high deductibles, et cetera, that's going to have an impact on premium. There's no way to get around that, I think. Okay, so moving on. Next slide, please, Rochelle. So this should be familiar. These are the policies that you all selected for evaluation at the retreat. And we want to talk now a little bit about our work plan going forward and how we're going to, and at what cadence we're going to dig deeper into these policies and come up with more specifics, evaluation of how they will be, how they could be implemented and what the impact of them would be if they were to be implemented. Next slide, please. So here's the work plan for 2024. We're in April now. At the May meeting, as listed on here, it says board policy topics. And then if we go to the next slide, you'll see that again in July. And then again in September, in October. One of the issues that we wanted to talk a little bit about today is how the policies, the order in which policies should be looked at, depending upon the access to data that will help inform the board with respect to those policies. And one on here listed in September are the OIC and AG's reports that are due. The OIC report, which is the final affordability report, will contain an actuarial analysis that will show if certain policies, including ones that the board is interested in, were implemented in the state, what would the financial impact of that would be? What would the savings be based on actuarial modeling of implementing those policies? And then the AG report is looking at consolidation, mergers, private equity investment, and some of the other issues that you all have talked about. So in terms of having the information that you all will need, that's kind of a date to bear in mind. Next slide, please. So we also have prepared and start. Yeah.
Gary, just to clarify, I'm not sure that the AG is going to be issuing an additional report. We're sort of checking in and trying to coordinate on our work. And if they did, they wouldn't have the capacity to do the kind of actuarial and economic analysis that OIC is doing on policy options. So
That's right.
I'm just like expectation setting here.
Right. So the next slide, staff, and we want to really thank staff for preparing this. I don't want to take any credit of authorship for this. This is a proposed framework for the board to use in evaluating these policies. And I'm not going to read through it, but I encourage you to look at it and think about it. It looks like a very robust and thoughtful way of identifying what the problems are, and then analyzing what the options are, what the impact would be, how effective they would be, how difficult they would be to implement, and so forth, leading to making recommendations. And in the few minutes that we have left, I know there's been some discussion of wanting to narrow down and focus on a couple of the policies that you all chose to look at, so that we make sure that we get as full and complete analysis and consideration of those policies and not spread ourselves too thin. So I want to kind of open that up for discussion in terms of whether that's something that the board, if the board has feelings about the order in which we would undertake further analysis of the policies.
Thank you, Gary. So yeah, that's the slide I was going to ask you all to come back to. So I guess I would pose the question, as Gary just did. How does the board feel about narrowing items on this list as we move forward? And are there things that are obviously going to come forward because of some of the reports? Like it seems like the M&A, the private equity, the ownership closures, that there will be some recommendations from the AG's office.
I'm not sure.
Not sure yet. And I have some thoughts about what we might be able to do to strengthen some of that reporting requirements, maybe add some conditions in there about medical debt. But I'm wondering how the board feels about the top two, since those were the big vote getters, and really focusing our work in that area.
Greg Marchand has his hand raised.
Oh, I can't see that. Thank you. Greg, go ahead.
Sue, I'm supportive of your suggestion of focusing on the top two. I think my only question is, are these all of kind of equal work or close to equal work in order to complete? But either way, I can certainly support the top two as the place to start.
Thank you for that, Greg. And I will just say that our work on hospital transparency will continue. We next month have, from the calendar you probably saw, we have other work that was in motion that is still coming back. So I don't want people to feel like, well, the hospital price transparency work that we were doing will fall away. It's coming back. And as many of you know, there's other reports that continue to come out. We haven't been able to talk about all of them today. The Lown study recently, there's several others from Johns Hopkins that we just haven't been able to mix in today because we had such other content. So I don't want you to feel like all these topics are going to fall away, but I think we would be wise as we go get ready to pack stuff into our report with recommendations, that we not be too broad, that we don't get anything done. And so I appreciate your comment of supporting too. I don't know who's next.
On the Eileen Cody.
Eileen, go ahead.
So I'm going to throw a monkey wrench at you. I have concerns about limiting it to just the top two, and I understand what you're saying, especially because after the Lowen report that came out on the fair share, we have 98% of our hospitals are not meeting the community benefit that they are receiving. So I have a lot of concerns about that. And then when I think about the statement was made that they want to see whether there's any anti-competitive clauses in any of the contracts. Well, we don't need to wait until the cattle are out of the barn before we shut the door. That's, the old farm girl has to give you that. So, and since I'm in Iowa, but I agree, like mergers and acquisitions, that a lot of that has already happened. That doesn't mean that there won't be more, or that the one big guy might gobble up another big guy. So I guess I'm just a little concerned about how limiting ourselves quickly. So that's all. I don't have an answer of how to do it because I know you guys are are stressed
I mean,
with, yeah.
Thank you for that. What I'm concerned about is getting the consultants doing and staff doing a deeper dive into some of these, and then I hear you. The other ones are important. It's not like we're going to stop work. We're going to look at where things are happening that possibly we could make forward momentum on those as well. So, as I mentioned, the price transparency that will continue next month. I'm not sure yet what to do with community benefit transparency, Eileen, but we are considering, like, are there ways that the industry could be reporting out to us? And or we make recommendations about that. And who's next? Who's next? Ingrid.
Except for Ingrid's.
My non-virtual hand is raised.
I see it.
Thank you. Eileen, I hear what you're saying, and I think there are some steps forward probably on all these fronts that we'll be attending to and observing. But in terms of the deeper dive, narrowing the deeper dive of this body, because there are multiple bodies working on these things, makes sense. And I think the two vote getters on the list is an interesting and natural pairing, because the provider rate setting and provider rate caps is very much long-term goal and high impact. And addressing an area of one of the largest cost drivers that would have even a major impact with being able to even begin to reduce the rate of growth. So that one is big. And then pairing it with a more targeted and focused issue around limiting facility fees, which is more something that could have a shorter term horizon of achieving lower intensity, and also is a cost driver, but is a smaller percent of overall health spending. So I think that the combination of those two makes a lot of sense. And it isn't that we wouldn't also attend to others, but for this board and the data available in this time frame, those make sense to narrow a deeper focus of exploration.
So I'm wondering, Andy and Michelle and Gary, if we couldn't come back with a more definitive work plan on the first two, but then looking at, are there other things going on? For example, building off of the OIC report or other strategies for some of the other areas, but the emphasis be on the first two.
We'll bring something back.
Is the board comfortable with that direction? I see lots of heads shaking in the room.
Sorry, I see Margaret Stanley has her hand raised.
Margaret, go ahead.
Yeah, I'm interested in seeing that. It's hard to really prioritize without knowing how much work is involved for working on these various policies. But I'm also interested in the options that we decided not to make a priority because other people are working on it. And I'm thinking in particular of administrative simplification. And I think it would be good to get reports back on the progress that's being made on that topic and how we can collaborate with other bodies to make sure that that moves forward.
Thank you for that, Margaret. That's a reminder that down there at the bottom where it says also forthcoming, not only will we bring over what the Universal Health Commission comes forward on that administrative cost work that they're doing, we'll be bringing over the primary care policy recommendations. So those were just, we don't need to get our consultants and staff kind of digging deeper there because they are definitely kind of delegated out to other groups and they will be coming back to our board. And I'm sure somehow in our report to the legislature, we'll point to how those things connect.
Yeah.
All right. I know we are we, where's my clock? Oh, we're past time. I am so sorry. I want to thank everybody for attending our meeting today. There is also some very good materials under tab 8. It's the draft of the benchmark briefing, a standalone summary of the slide presentation on the benchmark that we received in December. And please provide any comments that you may have by close of business on April 24th. I want to thank everybody for their time, their comments, their participation, and members of the public, thank you, those virtually and in the room. Thank you for being here with us. Also, a huge thanks to Noam Levy for joining us today and for shedding light on this hardship impacting so many families and individuals. To the public, I remind you that there is a recording and a summary of this meeting, and it will be posted shortly on our website. Our next meeting will be on May 15th, and we potentially have several large items on the agenda for that meeting. We may need to lengthen the meeting by 1 hour, and we are tentatively rescheduling the meeting to begin at 1 p.m. to accommodate that longer meeting. So please pay attention to your calendars. We always still love to see you in person, but we get it if it's easier for you to participate hybrid. We will confirm those times as we get closer, and we will be finalizing topics and speakers. And I look forward to seeing you all at the next meeting. Thank you again for all the work today. Meeting is adjourned.